بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته جميعا. Good evening, ladies and gentlemen and dear colleagues. I'm Dr. Iman Salman, consultant family physician. I'm very delighted today to moderate the first series of case-based discussion in hypertension management organized by Saudi Hypertension Management Society. Tonight, hopefully, we will discuss and highlight an important, challenging topic to most of us as a healthcare practitioners, which is difficult to control hypertension, or in other words, resistant hypertension. In this session, we will have two case-based discussion on how to approach such cases in real practice and learn clinical tips how to optimize the blood pressure goal. It will be an interactive discussion. You may actively participate by writing your answers in the chat. And at the end, both speakers will be more than happy to receive your additional questions. We will start with our first case, which will be discussed by our distinguished speaker, Dr. Hassan Al-Eid. He is a consultant, a transplant nephrologist, working in King Faisal Specialist Hospital and Research Center in Adult Transplant Nephrology, Kidney and Pancreas Transplantation Department in Riyadh. He is also one of the founders of board members at Shams. So let's welcome Dr. Hassan. Okay, you can share your slides. You have 30 minutes for the case-based discussion.
Sure. Thank you very much, Dr. Iman. Assalamu alaikum. Masal khair. It's a great honor to be with you tonight, and I'll be discussing with you one of our patients, illustrating some of the educational important tips in management of difficult to control hypertension. So what I'll try to do is give a brief introduction on difficult to control hypertension, and then give a case scenarios and put a few questions on the case. And you can read the question from now. Question one is, does this patient has renal artery stenosis? And question two is, like, how would we manage this patient? What therapy should we use? Should we use novel agent or no? And should we recommend this patient to undergo bariatric surgery or no? So, I'll conclude with my final remarks and recommendation. So when we look at the difficult to control hypertension, it's, as the word says, it's a blood pressure that require extra effort to achieve blood pressure goal. This extra effort could be, extra medication, like multiple medication, or it could be we need extra training for our patient, extra education for the patient to ensure that he's taking his medication, or extra workup like ruling out endocrine disease or renal artery stenosis. However, the definition of difficult to control hypertension is just arbitrary, and there's no specific point in that. More defined is resistant hypertension, and I think this is agreed upon by majority of hypertension society, is the blood pressure that remain above the target goal in spite of the concurrent use of at least 3 antihypertensive agents of different classes that include diuretic like chlorphalidone or indapamide, spironolactone, and these 3 agents should be at their maximum dose. If we have a patient with 3 antihypertensive with diuretics maximum dose, we call it hypertensive resistant. Even if we get good control of blood pressure with 4 agents, but it still require more than 3, so that would be resistant hypertension. And this a group of patients teaches something, that the average medication requirement and vast majority of hypertension trial is 2 to 3, and hence If we treat patient with 2 agent or 1 full dose agent and half dose second agent, then this is inadequate therapy. It's not hypertension resistant. This subgroup of patient has 2 important implication. Implication 1 is the potential for target organ damage is very high, which include heart failure, ischemic heart disease, kidney disease, stroke, etc. As you know, hypertension by itself is responsible for 50% of all strokes and more than 25% of cardiac disease and kidney disease. And this particular subgroup of patient carry the highest risk because obviously blood pressure is not controlled. Second, the likelihood of us finding secondary hypertension in these patients is high compared to all patients with hypertension. This is just a pathophysiologist slide of hypertension resistant. I think most of you have seen it. Kidney play a role as a filter. Heart also play a role, and brain either through a sympathetic nervous system or other endocrinal axis like renin, angiotensin, aldosterone system. When we look at resistant hypertension, I think they are just a usual hypertensive patient, except that we are missing some of the keys that can unlock their, our ability to control hypertension of these patients. And probably there are 4 categories of this, reason for resistant hypertension. Reason number 1, I would say measurement technique. We get the patient into the clinic and we measure blood pressure in the office, which is not the recommended technique. Patient would have slightly high blood pressure, or we're giving a patient inadequate medication, as I said earlier, like 1.5 to 2 medication, when we know that the average requirement is 2 to 3. Number 3, which is very common, way common beyond what we usually think, is adherence to medication and lifestyle. Our condition as hypertension in vast majority of time is asymptomatic disease. And we want the patient to take lifelong medication, and it may be 2 times a day, etc. And likely by passing through 3 to 6 months, a lot of patients will be non-adherent. Or there may be a biological reason for resistance, either chronic kidney disease, age, obese, primary hyperaldosteronism, etc. If we try to unfold some of these reasons, and I'm not going to give the details because details need specific allocated time for each one of them. But if you look at our clinic, in Saudi Arabia or in the whole country, in the whole world, you'd be amazed that less than 10% of clinics measure blood pressure in the appropriate technique in the offices or clinics. Vast majority of the time, patient come rushing. By the time he reached, they get seated in a chair, and before he greet everyone, the blood pressure measurement is taken, which is obviously wrong. And studies have shown that 20% of refractory or seemingly refractory hypertension are actually related to wrong measurement of blood pressure. And I think, we knew this from diabetes, that fasting blood glucose does not give you, any hint on how controlled is diabetes. And I think similarly, we should understand that one-time measurement of blood pressure when the patient comes to the office is similar to fasting glucose, does not give us, any hint on a blood pressure control on the at home and usual environment. And for that reason, I would say ambulatory blood pressure and home blood pressure devices, by today are actually mandatory. They're not complementary, anymore. We can go now to adequacy of therapy, and I would say that 50% of patients with hypertension do receive inadequate, therapy, and it's of paramount to say that this therapy should be simplified as much as possible and with the least side effect of the patient to encourage patient taking the medication. And when we look into the adherence, a trial on hypertension, we can see that 40% of patients are non-adherent or at least partially non-adherent, and 30% of patients who were enrolled in trials for refractory hypertension, they actually were found to be well controlled, just by observing them taking the medication. And hence, these three reasons, the measurement technique and adequacy of therapy and adherence to lifestyle and hypertension collectively can, correct more than 70% of cases that are labeled as resistant or difficult to control hypertension. With that long introduction, I'm gonna go to our patient. So our patient is a 65-year-old man referred to our clinic as a nephrologist to rule out renal artery stenosis. He presented 3 months prior to him presenting to me to a clinic, outpatient clinic, and at that time he was found to have blood pressure of 190 over 110. His weight was 110. And body mass index is 37. His exam did not show, any brewery or distinct, finding. There were some fundal, changes supporting hypertensive changes. He was treated with amlodipine 10 milligram, thiazide 25 milligram, and carvedilol 25 milligram twice a day. His initial lab data showed that creatinine is 175 micromole or 2 milligram, which gives an eGFR of around 34 ml per minute. His glucose was 400, and he had normal potassium 4 and normal bicarb. And his urine analysis showed albuminuria, and when that was quantified, he had 1 gram of protein a day. From history, he was treated with enalapril, but creatinine increased to 210 from 175. That's why he was referred to us to rule out renal artery stenosis. And taking more history, he told me that 10 years ago he was told to have high blood pressure and sugar, but he stopped his medication because he was given beta blocker that led to erectile dysfunction. He does have some knee pain, and sometimes he uses Voltaren. And with a quick screening, he also have symptoms suggestive of obstructive sleep apnea with snoring, daytime headache, and sleepiness. So, question, to the dear audience. Do you think this patient have renal artery stenosis? Should I investigate him or not? Option I gave here is patient had significant rise in creatinine, that is diagnostic of renal artery stenosis, or a patient has no other reason for resistant hypertension. 3, patient normal potassium, rule out renal artery stenosis, and 4, patient may have renal artery stenosis, however, diagnosis may not affect his management. I welcome all of you to participate. You can send your answer or in the chat. And I don't see any answer so far, but I'll be waiting for your answer. I'll give you a minute. And, you know, while waiting for your answer, you know, I'm not sure whether you have seen this, but significant number of patients, you know, they were diagnosed with hypertension or diabetes. They either receive like a prescription for 3 months, and then they stop. They do not refill it. They thought it is only for that, you know, certain period of time, and they stop taking it. Or they hope because they are asymptomatic, they can do well without, you know, any therapy, and just maybe these physicians are, you know, over treating the patient. I think that's enough time to choose.
Yes, Dr. Hassan, can I answer this question?
Please.
Yes, well, according to the history, the patient had significant rise in creatinine after starting ACE inhibitor, which also suggestive considering also his long-standing hypertension and diabetes and his non-compliance. He might have an advanced atherosclerosis and vascular hypertension. However, also from the history, he seems to be having several problems, including non-compliance, maybe due to side effects. So we have to make sure his compliance to his medication, although he is optimally on 3 drugs, including diuretic. Also, his renal function is also the EGFR. I don't know what was his previous one, or it is acute. Is it acute decline after starting enalapril? But also we have to rule out other causes as well, I think, in my opinion.
Thank you very much, Dr. Iman. So, you know, if I agree that, you know, when we have significant rise of creatinine, especially with ACE or ARB, this does raise the question of renal artery stenosis. However, you know, when we use ACE or ARB, and even to some extent other blood pressure agent that would reduce the kidney you know, perfusion pressure, we will have some rise in creatinine. I would say any rise that is below 30% should not be of significance. Here, the creatinine, you know, rose by around 25, 30, which is around 10% or so. So I would, or like 15%. So I wouldn't say that this is diagnostic, but I agree that, you know, rising creatinine, significant rise, should hint toward renal artery stenosis. There are other reasons for, you know, resistant hypertension, as Dr. Iman said. So his age, his chronic kidney disease, he is morbidly obese, and there are signs of or symptoms of obstructive sleep apnea. In addition, he does use non-steroidal, and as you know, non-steroidal does worsen blood pressure control. So if this is like an exam question and I have only one choice, I would probably choose number 4. So he may have renal artery stenosis. However, you know, this may not affect his management. So what we did actually, because he was referred to us to rule out renal artery stenosis, we did Doppler ultrasound and showed like perfectly normal kidneys and equal in size both sides, and there are by Doppler no features suggestive of renal artery stenosis. You know, alternative diagnostic technique are there, but it may carry risk like contrast CT or angiogram, or even contrast MRA. And I think probably the benefit, the risk benefit here is more toward risk. That's why we did not pursue it further. We looked into his, you know, other organ and other risk for cardiovascular disease. So he does have left ventricular hypertrophy by ECG, and he is also, you know, if you look at his lipid profile, is very high. His total cholesterol is like very high. LDL is sky high. and his hemoglobin A1C is 11. So, and when we look into the outcome, as I said, this patient may have renal artery stenosis, but impact on management, I think, is almost nil now. There are, 3 at least randomized controlled trial that looked into medical management alone versus a stent on top of medical management, and you can see that the two curves overlay each other. Basically, there was no difference in outcome at all, and hence vast majority of people would stop doing stenting for such patient. And now, I'm faced with this patient and with the complexity of his problem. So now he has hypertension urgency. His blood pressure is 190/110. He does have like poorly controlled diabetes. He does have chronic kidney disease, and as I said, his GFR, which we can calculate, whenever we have a creatinine. If we look into any navigator, a GFR calculator, we can calculate it. Here it is 34 with 1 gram of albuminuria. He does have a cardiac target damage with LVH. I'm not sure whether he have also coronary artery disease or no. And as I said, some knee problem, morbid obesity, and obstructive sleep apnea. And when such patient comes to the clinic, they trust us as a specialist. They have probably passed through a few other colleagues, and now they came to us, so they have the trust. But at the same time, they are fatigued because several regimens have been tried before, and their problem is maybe difficult to control. That's why they are referred to us. So we need to build on the trust, but not to cause further fatigue of these patients. When we look into the causes of chronic kidney disease in the kingdom and in the USA, and this is the data from the Saudi Center of Organ Transplant that look into causes of kidney disease in Saudi Arabia. You can see here in purple and blue that hypertension and diabetes cause more than 70% of kidney disease. And this is extremely important, finding, because we know that diabetes and hypertension are modifiable risk factor. They are preventable, we can prevent them. And once diagnosed, we can modify their natural course, and we can prevent at least 50% of target organ damage in these patients. This is not only in the Kingdom of Saudi Arabia, we can see it worldwide. This is data from United States. You can see diabetes and hypertension are both growing as a cause of kidney disease, while other causes like glomerulonephritis or cystic disease and heart disease are flat. This is important, as I said, because one side it is increasing. The second is these are modifiable, preventable risk, and we should work, into preventing them. So a question now, we have faced with all of these problems. What is the prognosis, and what should we tell this patient, or at least what is the image in our mind? What is his prognosis? Is it that mortality is very high, and annual mortality may reach up to 15%, or no, that's too high? Maybe that the chance of kidney failure is higher than the cardiovascular event, so his chance of reaching kidney failure is higher than chance of cardiac event, or he has low risk of stroke, or for both cardiac event and kidney failure risk are high, but the mortality is relatively okay, less than 5% per year. You can choose one of these options. And I hope that you will take less time, because this is a shorter question, and now you are, on top of the problem. You know, among the problem with the hypertension and diabetes in the kingdom, that the patient awareness of disease is low. Unfortunately, you know, less than 50% of our patients with hypertension and diabetes are aware of their disease, and hence they would present late to us, similar to this patient. You know, earlier detection of this problem is of paramount importance and can prevent a lot of target organ damage.
Dr. Hassan, we have got several answers. Some answer almost 50%. They answer 4. Number 4, both cardiac events and kidney failure risk is high. And we have some got the answer 2 or 1.
Okay, so you know, I probably would have answered the same for it, but when we read more into the natural progression of diabetic hypertensive patient with the chronic kidney disease stage 3, let's talk about number 2. The chance of reaching cardiovascular event and dying from cardiovascular event is actually 10 times the chance of reaching end-stage renal disease, meaning that because of the high mortality of cardiovascular event, most of patients would die before even reaching end-stage renal disease. Number 3 is obviously wrong. Number 4, both cardiac event and kidney failure risk is high, but the mortality is not 5%. Mortality, unfortunately, is annual up to 15%. And I'll show you a slide on this. But before, I want to show you the heat map of, clinical outcome of patient with chronic kidney disease. And as we drop a stage of chronic kidney disease and GFR from stage 1 to 3 and 4 and 5, our patient is here, moderately severe decreased GFR, stage 3B. And when we look into his albuminuria category, we said that he had up to 1 gram. So he's here more than anything above 300 milligram. He's in severely increased albuminuria. So here he is on, unfortunately, the red zone of the heat map, which carry high cardiovascular event, high stroke, high renal failure, and high mortality. And how high is that? We can look here into stage 3 in the green bottom, a green bar column. You can see diabetic with cardiovascular disease and stage 3 kidney disease, they have 15% annual mortality rate. This is 150 per 1,000. So this is 15% annual mortality rate. And unfortunately, this is extremely high mortality, and it goes even higher on stage 4 and 5. So that's why, you know, if we look at the number needed to treat to control these patients, diabetes and hypertension, and we get them into good control, you would probably need 10 patients to treat well to save 1 life, which is extremely important because that would give you, you know, the reward of your intervention and your treatment effect. Okay, now I want, and I'm sure you all want, to treat him and get a better control. And you want to control his blood pressure, you want to control his diabetes, his weight, etc. But with his degree of hypertension, kidney disease, and diabetes, which is true about this medication. Is metformin contraindicated? He had GFR of 34. Is canagliflozin, which is a sodium glucose co-transporter in the kidney, has no evidence in such patient, or ACE inhibitor and angiotensin receptor blocker are the first line of therapy, first agent to use for such patient. Number 4, phenrenone and spironolactone which both are aldosterone, antagonist. Both of them are not advised. And I'll wait for your choice. Luckily over the past 5 years, there have been significant development in some of the agents that I think have added significant improvement in patients with hypertension and kidney disease and cardiovascular risk. I think some of these agents are already available in most of the large hospitals. They are available also, some of them are available in Ministry of Health clinic. And metformin obviously is our old friend that made it surviving in all endocrine guideline to be used so far as the first line agent for diabetes. Okay, so Dr. Iman.
We have got number 3. Most of the audience answers.
Absolutely.
Number
so
3
I think,
option.
Absolutely. So, I think this is now probably for the last 30 years or so, there are obvious large and good randomized controlled trial of very good quality that showed evidence supporting ACE and ARB in diabetic patient with proteinuria. So when I saw this patient, I thought, my thought in mind, let's control his blood pressure first. And agent is to use. We have good evidence of ACE and ARB, and they have 25% protection, and this across all of them. So we have more than 10, long acting that can be used once a day of angiotensin receptor blocker or inhibitor. Some of them are stronger than the other in form of a blood pressure control. Some of them are weak, like losartan. Some of them are very strong, but they all have 25% target organ protection for kidney and heart. We have, studies on phenrenone, recent study that have showed 18% protection if they are used on top of ACE and ARB, and similar, data were shown for cardiac event with spironolactone. However, spironolactone had a problem with high potassium, and our ability to use it in patients with chronic kidney disease is limited. Now there are strong and multiple evidence support that sodium glucose co-transporter blocker agent can provide at minimum 25% protection of kidney event. And if we sum all of these, we would be able to prevent around 60% of kidney disease. This ACE and ARB evidence goes back to before year 2000, and for the last 25 years we did not have any. And luckily, on the last 2-3 years, we're getting these two that have, I think, added significant protection of kidney and cardiac disease. Question is, what target to achieve of a blood pressure? And then the second question is diabetes, and then the weight and his lipid, and I don't want to cause further problem to the knees. I want him to avoid non-steroidal usage, and hence, I'm going to be adding medication that will protect his organ from failing and ultimately, maintain his survival. But at the same time, I want to maintain the quality of life and gain of his trust, because if I give him a polypharmacy of 10 medication, he would just stop them, similar to what he did 10 years ago. So when we look into angiotensin receptor blocker, this is the IDNT trial that was published in year 2000, 20 years ago, that showed irbesartan versus amlodipine. Irbesartan had 25% less risk of kidney failure. Similar studies with losartan, telmisartan, and several other agents. I don't want to mention name, but I would say all of them do provide good protection to the kidney, and they are the first line agent, as you all answered in the choices here. Finrenone, which is a non-steroidal antagonist of for aldosterone. It's similar to spironolactone, but it has added advantage, and we can see that there is 18% reduction of kidney disease when we use finrenone on top of maximum dose of beta blocker. On top of maximum dose of angiotensin receptor blocker. If you remember the study on target, we could not use ACE inhibitor or ARB together. Now we can use finrenone on top of the maximum dose of angiotensin receptor blocker, and that would give us 18% further protection. I'm sure that we all like to see that the albumin coming down, because reducing albuminuria protect the kidney and also protect the heart. And we may be worried about potassium, but you can see placebo versus finrenone, there was no major difference in potassium, saying that we can use it, and hopefully, at least in 95% of patients, we will not have high potassium. Hyperkalemia was there in less than 5%. The third class of medication is sodium glucose cotransporter. And we have at least 4 or 5 of them, and I'm going to use one of them here, empagliflozin. And when empagliflozin used compared to placebo, we can have a clear effect on mortality, clear effect in kidney outcome, and in heart failure. So you can see here 25% reduction in primary outcome, including kidney disease, and 30% reduction in admission and hospitalization for heart failure. Saying that you can protect 30% of your CCU bed from admission with heart failure, or 25% of mortality, kidney disease, and ischemic heart disease. And this is the same for not only to empagliflozin, it is same for canagliflozin and dapagliflozin. And it is same whether used in diabetic or non-diabetic patient. An important caveat is initially when they first used, they were used in near normal GFR. Now there are at least 3 trials that use them in GFR of around 20 to 30, so we can still use it in our patients. The change in GFR, and I think this is an important slide. Whether we use empagliflozin, ACE, or ARB, or even just blood pressure control, we will see a drop in GFR compared to placebo. So the initial dip or drop in GFR will be there. That would be probably around 3 to 5 ml of GFR per minute. But if you can see the slope, we had a drop here, but then the slope would be more flat in comparison to placebo steep slope, and ultimately we would have a significant difference in GFR favoring the empagliflozin. And when it comes to a target, what target blood pressure should we use? I think target of such patient in Saudi hypertension management group and in American, guideline, European, I think all agree that these patients with significant albuminuria, they should have target of a blood pressure below 130/80. It's not one reading. We better get it a range because we know that when we drop a blood pressure further, they may have worse outcomes. So blood pressure around 120/30 and between 70 to 80 millimeter mercury, as the study of Sprint trial showed, it would protect the kidney and would lead to reduction in cardiovascular death and mortality. Diabetes, I think we could use metformin cautiously, in GFR below 45/30. We can use half dose of metformin. Sodium glucose, as I said, there are 3-4 agents of them. There is also data on GLP-1 like liraglutide and semaglutide that have shown a good diabetes control, good weight reduction, and also some improvement in blood pressure. This is semaglutide. It's a once a week injection, and you can see that the primary outcome of semaglutide was by far better than placebo with 25% protection. Same for non-fatal myocardial infarction and stroke. However, semaglutide, it did also reduce hemoglobin A1C, and it did reduce weight by around 5 kilos. This is over like a period of 2 years. However, it's very expensive. As you know, it costs something like 3,000 to 4,000 per patient per month, which is very expensive. So in that patient, we got him some fair control of his blood pressure. Blood pressure reached 140/85. And his hemoglobin A1C, if you remember, was around 11. Now it is 8. The blood pressure came down. Lipid came down. So his LDL now is a 3, still above target. We're not yet there, but better than before. He still has some albuminuria, and his echocardiogram showed normal ejection fraction. He has moderate LVH, and creatinine with all of this is now better. It's 150. Potassium on the edge is around 5, and he's on 8 medication: irbesartan, amlodipine, spironolactone, furosemide, PRN for edema, atorvastatin, empagliflozin, metformin, liraglutide, and aspirin. And he asked me, instead of all of these medication, doctor, can we just do bariatric surgery and get rid of at least some of the medication? So what should I answer him? Should I say gastric sleeve surgery has no impact on diabetes, or I would say no, that diabetic type 2, they are obese, they have insulin resistant, they all should go for bariatric surgery? Or should I say, well, the risk benefit assessment should be done before doing it, and that should include the short term and the long term, cardiac event and risk assessment? That sounds a fancy statement, and most of the MCQs is like this, and then it turned to be the true statement. Or should I say no, that the data from observational study does not support bariatric surgery in these patients? So I'll wait for your answer. And this is the last question. I know I took some of Dr. Badr al-Mustafa time. And I always like to listen to Dr. Mustafa. So if you could rush answering and help Dr. Iman giving us the answer.
I think most of the audience answered number 3.
Okay, yeah, I told you, you know, it sounds like a fancy statement, but it's true, you know. Before we send patient for, you know, bariatric surgery, I think we have to do proper cardiac assessment for risk. If we send all the patients, some of them may develop MI on table. And ultimately, I think the long-term outcome is good and encouraging. So we did actually gastric sleeve surgery. You know, luckily this patient presented 2019 before the Corona time, and we were able to send him for surgery. And his weight dropped, or improved from 110 to 80. The whole surgery, you know, it was not done at our hospital. It was done in a private center. It cost him something like 25,000 Saudi riyal. That is cheaper than, you know, maintaining him on some of the medication like semaglutide for 6 months or so. I'm withdrawing medication now. So I stopped metformin, I stopped amlodipine. I stopped metformin because he could not tolerate it after the sleeve surgery. They have more, stomach-related symptoms. I stopped amlodipine. I stopped the furosemide. I'm stopping more medication as time goes. And I always say that this is, gastric sleeve surgery is a way to lose weight if you are like disabled. In Arabic, I say it like juhd al-ajizin. I would rather, do it by physical exercise and diet. And, one of my patients who is like a copy paste of this patient, we had the same discussion about his clinical condition. And when I told him, I discussed with him, he joined Riyadh cyclist group. You can see them. They have like a regular every week, exercise. And this is with his permission. He's here in the picture. He used to have a BMI of 37. He's like 58-year-old. And now he's not, he's like now professional cyclist. And I used to counsel him, encouraging to lose weight and exercise. And now actually every time he comes to the clinic, he counsels me to exercise and move and stay fit. I think this is probably the best slide to end the presentation with. And I would conclude that resistant hypertension is using 3 different classes of medication at the maximum dose that include diuretics. Ambulatory blood pressure monitoring and home blood pressure monitoring, I think, are a must now. We should not depend on office-based. Average patient requirement will be 2 to 3 medication to achieve the target goal. 70% of apparent resistant hypertension are related to either measurement error or inadequate therapy or adherence to medication and lifestyle issues. There are strong evidence now that support ACE inhibitor ARB from more than 25 years ago, and new evidence support SGL2 and phenrenone and GLP-1 medication, and obviously on selected patient, not all patients, but in selected patient bariatric surgery. And I think at the center of all of this is the patient. So empowering the patient and getting his enthusiasm and him being, a member of the team and has the dynamic role and active role is essential to achieve long-lasting organ protection. With that, I want to conclude and thank you very much. And I'm sorry to Dr. Badr Mustafa, I took a lot of his time.
Well, thank you, Dr. Hassan, for your very informative and comprehensive approach. It was really amazing case that tackle lot of cardiovascular risk factor in a holistic way. We may continue with the discussion with Dr. Hassan, and we may postpone the case of Dr. Badr since we are short of time. You really covered a lot of aspects in the case, Dr. Hassan. We have several questions received from the audience, and I will suggest that if from the audience that they have any questions, we can continue our discussion with Dr. Hassan. I will just start with the first question from one of the audience. What is the preference agent in case like in this case with chronic kidney disease stage 3? Is there any preference between ACE and herbs, or it is the same effect?
It is exactly the same effect. So we have randomized controlled trial that compared ACE inhibitor on target. So we have on target trial that compared. Is it on target? I think it's on target that compared ACE inhibitor, lisinopril, compared to angiotensin receptor blocker, and there was no difference at all.
The other question is about the use of SGLT2 in very low EGFR. It is recommended by the most of the guidelines that cannot be initiated when the EGFR is very low, especially below 45.
True. Absolutely. So the initial, this is evolving, and I'm sure you would see the guideline being modified probably every 6 months now. The initial trial with empagliflozin restricted it to patients with GFR above, 40. Subsequent to this, canagliflozin chronic kidney disease trial was actually only in patients with chronic kidney disease, and it included patients with GFR from 25 and above with albuminuria, and it showed amazing result. Subsequent to this dapagliflozin trial and empagliflozin heart failure trial, they included patients with GFR above 20. So I would say based on a very strong, very well conducted randomized controlled trial, which would be leading to modification of the guideline to allow this agent to be used when the GFR is above 20. Actually, I would say that they also have advantage of, as a diuretics because of, they get rid of sodium and glucose and that drag water with them. They also help in excreting potassium. So in dapagliflozin trial, they have used it as a potassium lowering agent, and it was successful.
So in conclusion, we can use them with the low EGFR.
If GFR is above 20.
Above 20, yeah. Yeah. Okay. And what is with your experience with SGLT2? Because now it is available in our centers in MOH, empagliflozin. We can dispense it to our patient through Wasfati. We start using it, but cautiously. We don't have a good experience in it. So tell us your experience with your patient, the empagliflozin use, and those who are diabetic at high cardiovascular risk and controlled diabetes, with regard to weight loss and control, and whether a rising side effect like recurrent UTI or sepsis related to kidney problem.
So, and this is not limited to empagliflozin. It applied to all, same for canagliflozin and dapagliflozin. They're very good in preventing heart failure. They would help probably losing 3 to 5 kg of edema. and hence heart failure will be less. They improve hemoglobin A1C probably by around 1% or so. Kidney effect, they are positive. I have seen this dip of GFR as in here. Some patients may have more than this, like they would lose beyond 5 and 6 mil of GFR, particularly patients who are on diuretics, high dose, and hence I would probably start reducing the and lowering the diuretics dose. In form of other side effect like recurrent UTI, I did not honestly see recurrent UTI in the patient that I have used it in. However, if you have a patient, like for example, elder lady with diabetes and recurrent UTI, I would not suggest to use it because it would just make it worsen. As you know, bacteria love sugar. The dreadful complication is the fungal infection. I haven't seen it in the literature. It is something around 5 patient per 1,000 patient or so. Luckily, alhamdulillah, I did not see any of these complications.
Great, that will encourage us to use it more, hopefully. Okay, another question. What is the difference? You labeled your patient in your case as an urgency hypertension. What make you to say so if it is not an emergency hypertension?
His blood pressure when he came was 190 over 110. There are target organ damage like LVH, proteinuria, chronic kidney disease, but there are no acute target organ damage. So he does not have heart failure, acute coronary syndrome. His kidney function is not acutely rising. So there is no acute target organ damage caused by this high blood pressure. And as you know, if we do not have acute target organ damage on top of the chronic, this should be hypertension urgency, not emergency. Emergency is defined basically by the presence of acute target organ damage.
Yeah, very nice. Thank you, Dr. Hassan. Another question, you have mentioned that almost 20% of difficult to control or resistant hypertension are caused by inappropriate measurement. And here there is a question from the audience that whether ambulatory blood pressure monitor much better than home blood pressure measurement in estimating cardiovascular risk and diagnosis or establishing the diagnosis of hypertension.
Ambulatory blood pressure is the best measurement technique that correlate with outcome. When we look into cardiac event, mortality of the patient, development of organ damage, ambulatory blood pressure measurement technique is the best validated and correlated with outcome. However, as you know, it's not available in all clinics, and it some patient may do it like once a year or so. However, the home blood pressure monitoring has other advantage. It does have advantage of having patient actively, measuring his blood pressure, and he can see his reading by himself, and that actually increase his adherence and also his active role in the blood pressure control. Because you do ambulatory blood pressure once in the clinic every 3 to 4 months, but this home measurement, he can do it every day, every week, whenever he has symptoms or so. So I would say, though this is opinion-based, not evidence-based, that home blood pressure, if it is done in the appropriate way and technique, can give you the same information of ambulatory blood pressure, and it is cheaper. Now there are, as you know, small machine that can be used at home, and they can transmit and record the data to smartphones, and that can be like emailed or sent to the clinic or to the physician, etc. So it does actually improve the blood pressure treatment. And I would, say it again, fasting glucose does not give us, a hint on sugar control. Similarly, one-time reading in the clinic does not really give us good capture on degree of hypertension on blood pressure control.
Yes, definitely, Dr. Hassan. Okay, is there any way to increase the accuracy of home blood pressure if we depend on the patient to measure it at home and we based our clinical decision on these readings? So is there any special instructions on device or on the technique, how many times during the day? Is it the systolic or the diastolic or both?
I think that's the essential element of home blood pressure. The most important part is educating the patient how to use it, which basically applying the same principle of appropriate technique of measurement of blood pressure in the clinic. Patient should be seated at least for 5 minutes, no coffee or exercise for the last 30 minutes. His back and legs should be supported. He should not cross the legs, etc. I think this need a special training session to our patients. So it's not that go and buy this type of blood pressure agent or machine and measure your blood pressure at home. Patient should be educated by instructor or physician or a nurse. I think if we achieve this, then we can benefit from home blood pressure monitoring. If we cannot, then home blood pressure monitoring would be same like office-based. When it comes, is it diastolic and systolic? I think both are important. Studies showed that in young, diastolic is probably more common. In elder or old, systolic blood pressure are actually more prevalent and more difficult to control. And a patient can do it 2 or 3 times, per day and several days in a week for any change in blood pressure and to achieve control. And once control is achieved, they can reduce the frequency of measurement.
And with regard to reading the blood pressure reading, the home blood pressure reading, usually we will take the average readings per day or per week or what?
As you know, all audience, Dr. Iman is actually our expert in Saudi Society of Hypertension for home blood pressure machine and reading. She's asking me, and I would say yes, they should take the average of the reading. And typically similar in the clinic, we should take like 2 to 3 measurement, and then we should take the average. And the new automated oscillatory blood pressure machine in the clinic, similar to the Sprint trial machine, they used 2 to 3 reading and they took the average of the whole reading. Any other question or comment? Yeah, please, Dr. Iman.
Yes, Dr. Hassan. I talk and it was mute. Regarding the finerenone, is it available in the Saudi market, and what are the indications to use it?
Finerenone was just published. The data was, new. It was just published last year in October. I don't think it is yet available, but I'm sure that it would be available in very near future. I wouldn't be surprised that it would be available, before the end of this year. However, meanwhile, until we get it, you can use spironolactone. Finerenone has advantage over spironolactone, not only on hyperkalemia, but it is a highly selective agent, and it has high affinity for both receptor in the heart and in the kidney. That's why I think the effect would be better than spironolactone. But meanwhile, if you have a patient who does not have hyperkalemia issue, then spironolactone should do.
With regard to the hyperkalemia that is caused by spironolactone, if we combine it with ACE inhibitor, how to monitor such patient and avoid the hazardous issues of hyperkalemia?
As you know, on the RALS trial, which was published probably 15 years ago or so, that showed, very good cardiac outcome, but in patients with chronic kidney disease, they have significant high degree of hyperkalemia, more than 15%. And if you couple that with use with ACE inhibitor or ARB, definitely that would be an issue. I would say probably you would be able to use it in 50% of patient, but in 50% of patients you will not be able to use. I would suggest any patient at baseline with potassium into 4.8 and above, we should not start spironolactone if we're using ACE or ARB.
Can you repeat the level of potassium that
above? If we have before starting spironolactone, if we have a potassium above 4.8, the likelihood of potassium going into above 5.5 is high. On average, if you look into the study, on average, spironolactone will lead to increase in potassium between 0.5 to 1.5, and hence that will lead to a high potassium and like above 5.5 in majority of the time if the baseline potassium is above 4.8.
Yes, very clear. Okay, another question, that this patient is high cardiovascular risk since his chronic kidney disease. Is aspirin recommended for primary prevention for this patient? Knowing that the high likelihood of upper GI bleeding, or he might have high risk since he have chronic kidney disease of bleeding, how to weight the benefit versus risk in this patient?
I think that's a very important question. Unfortunately, we don't have data to directly answer the question. There is no large randomized controlled trial on aspirin in patients with chronic kidney disease stage 3 and above. We know that the chance of bleeding, they are at higher risk. And we also know that they are at higher risk of atherosclerotic thrombosis and target coronary and cerebral infarct. However, there are no trial to answer this, but I would say in patients who have multiple risk factors similar to this patient, I would probably use it. And patients who have less risk factor, like only diabetes which is controlled or hypertension which is controlled, I would probably not use aspirin for primary prevention. For secondary prevention, the rule is there; it should apply similar to all other patients.
Yes, thank you. It is really a big dilemma, the aspirin now. Another question for this patient, he is having multiple knee pain, and maybe most of our patients, they will insist on using non-steroidal, otherwise they cannot move or something like that. So is there any agent that is of non-steroidal that is a little bit safer than the others that can be used?
Yeah, all non-steroidal, selective and non-selective, are dangerous on the kidney. Unfortunately, you know, they are very good in treating musculoskeletal pain. And, you know, I always think of our patient, you know, he has pain and he take a non-steroidal that give him a relief. He does have hypertension, but does not give him any symptoms. And I want to trade taking medication for no symptoms versus taking medication with symptoms. However, we know that all non-steroidal, selective and non-selective, are dangerous on the kidney. They're dangerous also in blood pressure. They can cause fluid retention and heart failure. Whether, you know, old generation like Voltaren indomethacid or the newer, you know, COX blocker and inhibitor, they are all cause the same. In form of pain, unfortunately, we can only use Benadryl-based or Tylenol-based painkiller. We can use non-steroidal cream and ointment. You know, they are locally absorbed and they don't go into circulation and they don't cause kidney disease. So, for example, for back pain or knee, we can use them as a cream or ointment.
Another question about the use of ACE inhibitor and SGLT2. Should we stop them in case when the eGFR deteriorated, and when? What is the maximum limit? Or,
you know, for ACE inhibitor and angiotensin receptor blocker, there are now randomized controlled trial that show when we stop ACE or ARB, especially when the GFR drop below 15, we have advantage and big advantage. The advantage we would prevent hyperkalemia, we would slightly improve GFR, because as we have seen, you know, in the curve here, that if we take them out, GFR will improve, and that would improve by 2 to 3 millimeter, and that may avoid the initial use of dialysis. However, a study is published in Lancet. If you stop them at the terminal GFR, the mortality increase and the cardiac event increase. And that increase is by far outweigh the small benefit of avoiding dialysis. So I would say, unless there is other reason, I would not stop them. I would stop them in patient who like goes into hypovolemia, like diarrhea or other reason. I will stop them temporarily. I will put them back. For the SGL2, I think data are still lacking. So, and reading the trial, we could not see patient dropping GFR to that degree, because all studies have used it in GFR above 20.
Yes, thank you very much. What is the best treatment? This is the last question, because we are almost at the end of our event. What is the best treatment of diabetes with hypertension if the patient cannot tolerate ACE inhibitor or ARBs?
If they cannot tolerate ACE or ARB, then it would be finerenone or spironolactone. They have the same exactly effect in form of blood pressure, in form of reduction of albuminuria and kidney protection. And even if the patient does not have diabetes, similar to DABA study, I would use SGL2 inhibitor. They also improve kidney outcome, even in non-diabetic patients.
Yes, thank you very much, Dr. Hassan, for this very informative. Thank you for your patience to answering almost. We have got all the questions from our audience. I would like, on the behalf of Shams, I would like to thank the audience as well as Dr. Hassan Al-Eid for his very informative case-based discussion. And apologize for Dr. Badr that we really unfortunate we didn't hear from him. But we are looking for, in the near future, inshallah, we'll arrange it and we'll compensate for this missing case. This is the first series. Inshallah, we will meet in the near future with the second case-based series in hypertension management. Hope we will meet you soon. Thank a lot for your interaction. Thanks for the audience. And inshallah, we will meet soon in the new events. Thank you very much.
Thank you.
Assalamu alaikum.